Hello, one and all. Welcome back to the Podiatric Dermatology monthly wrap-up. We've missed a couple of months, so apologies for that. Joseph and I have had a little bit going on in our lives, but we're
Good
back
things.
with you now. All good things. And we are back with a new episode today. Thank you for joining us. Today, Joseph, we are having a look at, we're doing a bit of a pediatric focus today.
Yes, we
aren't
are. It's all about the kids because they are the future. I'm about to go into some sort of Michael Jackson reference there.
The children are our future.
Children are our future, that's right.
And
yeah.
they're also very warty. So we're going to have a little look at warts.
Yes, don't we love warts? What are warts also known as, Stephanie?
Verrucas, if you're
Yes.
from the UK, or verrucopetus, if you want to be very precise.
Absolutely. And do you know why they call... Oh, sorry, we've gone to the wrong slide. Apologies, everyone.
Oh, you're too excited. It's been too long.
I did
Calm
get too
down.
excited. There we go. Okay. We were going slightly out of order there.
Excellent.
So verruca... the origin is unknown of the actual term, although there is some theory that it means small hill, also known as hillock, which actually makes sense. So verrucae, or also known as warts, are viruses, and they're viruses that can infect anywhere. And there are, guess how many subtypes, Steph?
I'm going to say, be very precise and say 47.
You are very close. All you need to do is multiply that number by roughly 3. It is 150 subtypes. Did you know?
Wow. I did not know that.
There are a lot of them.
Terrifying, actually.
Terrifying and horrifying.
And do you find approximately 149 of those at your local pool?
Oh, yes. Fair point. What's interesting is different subtypes tend to infect different areas. Some of them can be absolutely lethal, but most of them are mercifully benign. The lethal ones are the strains that commonly cause cervical cancer. So the pediatric vaccine known as Gardasil is actually a mild dose of the human papillomavirus, which reduces the transmission of cervical cancer, which is an STD. But specifically in pediatric cutaneous warts, we normally see verrucopetus, which is typically subtypes 1 to, off the top of my head, I believe we can get up to subtype 57. I will have to confirm exactly the subtypes. What's interesting, though, is each subtype produces a slightly different clinical manifestation. So that means that subtype 1, also known as myrmecial warts, which are little anthill warts.
Now you're just showing off.
Well, I'm trying. So they're single warts. There can be multiple single warts, but they don't tend to form a scale. They don't tend to kind of move through in a pattern. So, which leads us to subtype 2, which starts with an M. You've probably heard of it, Steph.
Mosaic.
Well done.
Nice.
So mosaic warts are the other type, and
also my favorite.
Oh, why is that?
I don't know. It's a weird thing to have a favorite wart, isn't it? But
of all the warts,
of all the warts, yes, mosaics are my favorite.
Of all the warts that happen to walk onto your foot, mosaics are your favorite. And so yeah, they do have interesting clinical manifestations. But like Shakespeare didn't say a long time ago, we're getting very poetic today, to treat or not to treat. That is the question. So why would we not treat a wart, Steph, in your clinical opinion?
Well, because particularly for small people, they tend to just run their course over time.
That is
correct.
Leave
them alone.
That is correct. The statistics are roughly 50% of verrucopetus, or warts in general, clear within 6 months. So doing nothing is still doing something when it comes to warts. 90% clear within 2 years. So the question is whether or not we need to treat. So I would say in cases where you have pain, where you have numerous warts, where you have numerous family members with warts, and so therefore a reinfection cycle is happening, in cases such as that, I would treat. And what sort of treatments come to your head when you think about warts?
Well, I'm going to tell you a family favorite.
Oh, please do. Everyone has some grandma tale of warts or something like that.
So my beautiful Dutch Oma, when I was a child, decided that the way to get rid of warts, and I won't do the accent, is that I need to buy them off you.
Oh, lovely.
Right. So she would get a coin and put it onto the wart, which is fantastic for spreading. And then she'd say, there you go, I've bought the wart from you. So she'd give me the coin and say, it's mine now, it's going to go away. And of course, it worked every time. No, it didn't at all.
I've heard similar stories from other people's grandmothers. I've heard of people drawing a picture of the wart and destroying it. I've
Ooh,
heard
that's
of
very witchcrafty, isn't
yeah,
it?
I've heard of plant-based treatments from literal fruit and vegetables, garlic, lemon,
Lemon oil, right?
potato skin. I've heard of
Yes.
figs. I've heard of banana peels. I've heard of thuja. I've heard of
Can people just
marigold.
stop putting food on their feet, please? Like, just put it in your mouth, not the feet, your food.
I mean, I will say, despite the very low evidence, if any, of all of these treatments, they do tend to work. And maybe that's because of that whole clinical course nature of it. Maybe that's also because the treatments themselves have immunostimulatory properties. Because warts do self-resolve, a lot of it has to do with leveraging an immune response. And we are going to talk a little bit later on the episode of what the best evidence-based treatment is in the form of salicylic acid. So spoiler alert, we're going to be talking about salicylic acid. But why do you think warts are more common in kids?
Because kids are really grubby.
Pretty much. And they're also barefoot and they also don't wash well. And they're also exposed, arguably, to a lot of environments with warts. I mean, more kids would go to swimming lessons, particularly in a country like Australia, than adults. So, I mean, I actually can't remember the last time I went to a swimming pool. The beach, yes, but the swimming pool, no, I can't remember. It's mostly a pediatric thing. Kids do gymnastics, kids do PE and sport at school.
And then when they do get warts, they can't leave them alone.
Exactly. And so you get a process called auto-inoculation where you give yourself a wart. So you spread your hand warts to your feet and the foot warts to your hands.
Yes.
Where warts can get a little bit problematic is when they're not responding to treatment normally. And that's particularly in adult cases. So if you have lots of warts or you have a wart that no matter what you throw at it, it's not quite getting better, that's enough to necessitate a little bit of a further look with a biopsy or with a referral to a specialist, whether it's a dermatologist or a GP with an interest in it, just to see exactly what it is. I mean, some warts don't resolve on their own. In any case, just the nature of the complicated immunostimulatory aspects of the wart itself. But if unsure, seek help.
Yes.
Were there any other warty questions you have? Or have we covered it warts and all?
I don't think I think we've only just scratched the surface.
Oh, very good. I will say that the number of treatments out there that are evidence-based and painless are numerous. So whether it's your podiatrist, your GP, your nurse practitioner, your dermatologist, whoever is treating your wart, fear not, there is always another way to treat it that doesn't involve lots of pain. So there's always another option if you're pain averse and don't want it frozen or burnt off or something of that nature.
I think it's something that we do a lot on these episodes as well, is to get people to explain it in layman's terms. So
absolutely,
whenever I have treated a patient with a wart, I always like to explain to them it's a virus. It sits, at a level of the skin where the body can't detect that there is a virus there. And so the idea for treatment of this particular wart is to aggravate it to a point where you're putting like a little flag in it and saying to your body, there's something here that you need to sort out.
Eat me.
Yeah. So do you have a different way of explaining it, Joseph?
No, word for word.
Nice.
Word for word. And particularly in pediatric cases, because kids are worried when you tell them they have some sort of virus, especially given the infamy of the COVID pandemic when kids hear virus. Yeah,
and I think with adults too, when you say it's HPV, and they're like, "Excuse me,
hello,
I have an STD on my foot."
That's right.
No, thank you.
Yeah, what are you trying to say?
Yeah. What? I haven't been doing those things.
Yes, absolutely. Yes. Yeah. So no, absolutely, you're 100% right. Communication, which Steph and I are big fans of, is key. So clear messaging and simple languages. So speaking of simple things, let's go back to what we were sharing before. What does this look like to you?
To be fair, not on the fingers, but on the toes and the feet. It looks a bit tinnier-esque. I know it's not, though.
I like where you're going, but what would you say is the primary characteristic that you're seeing in the most simple terms?
Flaking, peeling skin.
100% right. So this is an interesting phenomena. It's called exfoliative keratolysis.
Ooh.
Yes.
So essentially keratolysis, lysis meaning to lift.
Yes. Keratin of skin
Mm-hmm.
and to exfoliate. Yes. So exfoliative keratolysis, and it's quite similar to this. I'm just going to get to the next slide, which is juvenile plantar dermatosis. So you've got
Ah.
essentially both of these have a number of overlapping features that we see in pediatric cases, typically pediatrics, sometimes adolescents, sometimes adulthood cases, where essentially the foot peels for reasons unknown. But within podiatry, we know that the foot is different. The foot is different, not just anatomically, but environmentally. So what does that mean? It means the actual structure of the foot and the hands are actually quite similar. They do have an extra skin layer. There's fibrofatty padding. There's a huge concentration of sweat glands in there. But the actual environment that we put our feet in is hot and sweaty. And so if we combine that with friction and we combine that perhaps even with other triggers, whether it's seasonal triggers or whether it's infectious triggers, we can get an exfoliative process. So it's, it's also known as backwards keratolysis exfoliativa, but essentially that's really what happens. It's just a process of just focal skin peeling. There seems to be a genetic component. So kids who get this problem, it's, family members that have it. And it does seem to be concurrent with hyperhidrosis, so excess sweating. So when people are sweaty, their skin tends to peel off a little bit easier. Yeah. So when you look at a problem like that, Steph, what sort of treatment comes to mind?
I'm not sure with that particular one, to be honest. I mean, can you use some keratolytics to help it along a little more,
It's an interesting
or
idea.
is that going to
Potentially.
damage?
Yeah, and that's actually an interesting perspective. It all depends on the strength. So yeah, you could use a very gentle one. And the other one with juvenile plantar dermatosis, it really depends on which season tends to affect it. So if it's a winter thing, so maybe at the end of the period, you can kind of nudge it along if it's related to winter, or if it's related to summer, you can nudge it along. But I mean, it is a bit of trial and error. There's no real hard evidence that, one treatment works over the other. But again, an accurate diagnosis is important because you want to make sure you're not dealing with psoriasis or eczema or something of that nature that, it can be quite irritating and have an inflammatory component to it.
And so I guess potentially then are you looking at sort of a two-pronged approach of you're maybe wanting to help that exfoliant, but you're also looking at the cause of it. So if it's due to, hyperhidrosis, treating the hyperhidrosis with, any like chemical agents or assessing your footwear and your socks or stockings or whatever. So you're looking at the whole of the person and what they need rather than just whacking something on it.
Absolutely. And 100% right. And it's kind of the opposite in terms of warts. Now, warts are transmitted through direct contact, whereas these kinds of peeling, sweat-related dermatoses are relieved by taking your shoes off. So often it's a case of trying to find that nice little simple moisture balance. And
so it's great if you want to get return patients. So they come in with this one, you get them to take their shoes off, and then they get a wart, and then they come back, and then the cycle continues.
Good news, we fixed your warts, but now you've got exfoliative keratolysis. So now you have to take your shoes off, which could lead to another wart. Yes, you're quite right. You're quite right. In cases like this, I would potentially look at a very light, occlusive moisturizer, something with dimethicone in it that would create a very thin barrier but would still moisturize. So you don't want a very strong occlusive with zinc oxide, which is
it's only going to make the sweating worse, right?
Correct. Yeah. I mean, you do want to protect and sort of add another layer of skin. Another layer.
Barrier layer.
Yeah. Thank you. That's the word.
That's the word.
That's the word.
It is late.
It is. Well, or it's early, depending on what part of the world you're listening to us. Yes, but
so true.
So you do want to create that extra barrier. But speaking of keratolytics, there is one that we mentioned earlier, salicylic acid. So when you think sal acid, do you think beauty or do you think dermatology?
Oh, look, because I'm a podiatrist, I think feet. And then, and then I watch Dr. Pimple Popper and she's always going on about sal acid and, has your skin treatment got salicylic acid in it? I'm like, I feel like I should go buy some.
Sal acid is great. It's very, very versatile. as
Oh,
Dr. Pimple
nice.
Popper would say. It's incredibly versatile. So you people, dermatologists, podiatrists, anyone that's in skin can use it for a number of different functions. You can use it for beauty. You can use it for fungus. You can use it for eczema. You can use it for psoriasis. You can use it for callus. You can use it for corns. You can use it for warts. I mean, I know I sound like I'm an advertisement for, some sort of magical 20-in-1
Is
product.
this sponsored by generic salicylic acid? Is that
Well,
what we're saying?
no, but it is a very versatile product. What's interesting is the keratolytic properties are enhanced by the longer it's left in place. So
Mhm.
specifically for wart treatments, we're looking at percentages between 40 and 80%. And the longer you leave it in place for, the greater keratolytic effect it has. So if you leave it in contact with the wart for 3 days, it will keratolyze deep. If you leave it on for a week, it's going to keratolyze almost down to the dermis. So what a unique property of it is when you leave it on for a number of days, and I'm sure you've seen this on your patients that put it on a corn plaster. What happens to the skin, Steph?
Oh, maceration
Absolutely.
and
Absolutely.
just total destruction. It's horrible.
Which is how it keratolyzes. So it's salicylic acid belongs to a family of hydroxy acid called beta hydroxy acids that are powerful humectants. So they draw water in from within the tissue, and they change the way the moisture balance works through each layer of skin. So it sort of draws water up and so from within it, so internally and externally, and it sort of makes this whole big mushy mess, which is very difficult to actually treat, particularly on the foot. So if we go back to plantar warts, what's unique about plantar warts is that they're inverse. If you think about where a wart is anywhere else on the body, it literally is like a little hill. It sits above the skin. But if a person is walking on a wart, it becomes pushed in. So what happens is when we put salicylic acid of a higher percentage on the actual lesion for 3+ days, all of that moisture stays in there. And so it's impossible to differentiate between what's been treated and what's not. So my general rule of thumb and my little pro tip is to actually leave it alone for a couple of weeks, and then it will just keratolyze and exfoliate on its own. So we've literally gone full circle. And also because warts are circular, but we've gone full circle in this whole discussion as to how salicylic acid works. But it is very versatile. It's very handy. And the effect tends to be cumulative. So, the more goes you go through, the more cycles of treatment you go through, the greater the peeling effect. So,
and in your experience, Joseph, how painful have you found that for your patients? Or is it all about how well you are occluding the healthy skin and how
really
well
great
you are
question.
targeting the wart?
So in general, salicylic acid doesn't cause that much pain. And you can put a donut pad, a bagel pad, some sort of protective layer around the actual wart in order to make sure that the salicylic acid is very targeted. But I wonder, and this is something perhaps to look into for another podcast episode, I'm pretty sure salicylic acid is related to aspirin. Pretty sure. So I wonder whether it has mild analgesic properties.
That's
I
interesting.
wonder. I mean, I could be wrong. We'll need to fact check that one later.
Potentially, and a little bit like phenol as well, where you get that slight
Perhaps.
numbing to it.
Perhaps, yes. Absolutely.
Interesting.
Yeah. So it's a powerful drug. It works really well, but it doesn't have to be an all or nothing approach. It can be used pulsed. It can be used cyclically. It doesn't have to be put it on and then keep putting it on. Let it do its thing and let the skin peel off so you can get a better idea of what's happening. It will do the work for you, whether that's a facial peel, whether that's an exfoliative foot product. I don't know whether you've heard of these foot peels that you stick your foot in this sort of plastic bag and you leave on some acids, and a week later.
I've seen some awful results from that. And patients coming in and they take their shoes off and get in the chair and you go, what has happened to your feet? And they go, oh, like 3 weeks ago, I did this foot peel and it won't stop peeling. And you're like, oh.
And that's exactly it. It's literally doing the work for you. So it's very versatile, but as always, under the supervision of your local health practitioner. And sometimes when it comes to these treatments, less is more. And we need to give the skin enough time to do its thing. I mean, it takes at least a month, sometimes 2, for the skin to turn itself over on the outer layer. So there's no rush. I think that about wraps it up. Have we covered anything else?
Oh, I think we've covered our top 3 that we were gonna do today.
I
We
think
didn't do
so
a
as well.
case study like we normally do, but that's quite
No.
all right. We've sort of gone into a dermatoses and a product and, a condition. So
Yeah,
I think we're good.
I think case studies will come and go, but our curiosity will remain.
Oh, you're such a dag.
Yes, I know, terrible. Anyway, thanks everyone for joining us. And Steph, as always, wonderful.
Thank you. And as ever, if anyone wants to engage on our socials, you can find us, put up a comment on YouTube, head over to Facebook and get to the Podiatric Dermatology Interest Group where you can ask all of your questions and have a lovely little community of pods who are very welcoming. And no question is too far gone. Or you can engage with us on Spotify as well.
Absolutely. Thanks for joining us, guys, and we will see you next month.
Sure will. Bye.